This lecture is about otitis media and tympanic membrane perforation. So we'll start with the otitis media. Otitis media is characterized by fluid in the middle ear. It's a group of inflammatory or infective processes that may be bacterial, fungal, or viral in origin, and is most often associated with upper respiratory tract infections or allergies. From an epidemiological standpoint, we know that otitis media is the most frequent childhood infectious illness, with a peak onset of about 6 to 15 months of age. It really accounts for a significant number of antimicrobial prescriptions in primary care. The severity and presentation vary. Symptoms and findings often are part of a continuum, despite the common practice of identifying discrete diagnoses. So acute otitis media with a bacterial or viral infection of the middle ear fluid usually has a rapid onset and short duration. As opposed to otitis media with effusion, the OME, it's an accumulation of serous fluid in the middle ear without acute inflammation. OME can precede or follow acute otitis media. And then there is the possibility of an MEE. The MEE is a middle ear effusion, and it's an accumulation of serous fluid in the middle ear, and it can be associated also with an AOM, but it often persists for weeks or months after an episode of an AOM. And then finally, chronic effusions, known as serous otitis media or glue ear, may persist for several months with or without signs of infection. Children are typically 3 to 7 years old or are most commonly affected, and recurrent otitis media is defined as 3 or more distinct episodes in 6 months or 4 more episodes preceding 12 months, with at least 1 episode in the past 6 months. So pathophysiology, we do know that otitis media is a dysfunction of the middle ear and the middle ear mucosa. Really the cause is multifactorial, related to anatomy, pathophysiology, and cell biology. We know the antecedent events may be viral, bacterial, or allergic. And upper respiratory tract infections or allergies often precede otitis and result in edema of the eustachian tubes and the nasopharynx. So those narrowed eustachian tubes, which are common in infants and children anyway, might be why they're predisposed for episodes of otitis media. Exposure to cigarette smoke acts several ways to increase the risk. We know smokers are at higher risk for upper respiratory infections, and we know that they also work on the mucociliary function in the eustachian tubes. So really, middle ear secretions accumulate in the eustachian tube, and that opportunity for the pathogen growth increases. So there's several pathogens that cause otitis media, but some of the most frequent are Streptococcus pneumoniae, Haemophilus influenza, that the group beta hemolytic Streptococcus or gas, Staphylococcus aureus, and Moraxella catarrhalis. But undoubtedly, bacteria is the most frequent cause of otitis infections. Clinical presentation, that's interesting because the otoscopic exam's key. You can't go on the symptomology, the history taking, the symptom. You have to look at that tympanic membrane. It requires a assessment with a pneumatic otoscope and adherence to defined diagnostic criteria, and one of those is the presence of bulging tympanic membrane. It's a critical part of an accurate diagnosis. It really helps you discriminate between an acute otitis media and an otitis media with effusion. So diagnostically, we should be using a pneumatic otoscope. We're looking for position, color, translucency, mobility. Tympanometry is very helpful in diagnosing. We can use Weber or Rene tests also. And then sometime lab tests with CBC with DIF, or when you suspect some cellulitis, or culturing ear drainage can be an important part of our diagnostic workup. Management and treatment, I did not put this on the screen. I just want you to realize that the AAP guidelines define the AOM types and recommended treatments. And I want you to look at those on page 375. Really looking first-line antibiotics that include amoxicillin and Augmentin, and then you can look at the alternative treatment, and that's initial treatment for AOM versus antibiotic treatment after 48 to 72 hours when you had a failure. So you go ahead and look at the addition or the change to Augmentin or to a third-generation cephalosporin such as Rocephin. But just take your time and look at that information on 375, 376. It's really important for us to be able to discriminate which bacteria is present and how we treat that appropriately. Referrals with otitis media are really those that don't respond to therapy within 48 to 72 hours. Acute otitis media that doesn't respond to therapy in 48 to 72 hours needs to be switched and refer back to your table to an alternative therapy. But you're also thinking if they're not going to respond to that alternative therapy, or their condition just simply deteriorates. Specialist referral for tympanocentesis for culture might be necessary for those non-responders. Speech and audiology for speech delay is really important. About 3 months of decreased hearing, and that's quite significant for a child that's developing speech. And ENT for tympanostomy tubes for recurrent acute otitis media. Patient and family education, really want to look at risk reduction and treatment. We need to explain the symptomatic treatment of the OME and MEE versus the acute otitis media, and why. We know that breastfeeding can reduce the risk of acute otitis media. The patient shouldn't be exposed to smoke. And then there's evidence that vaccine appropriate, age appropriate, that includes the pneumococcal vaccine, MCV7, and influenza have been shown to reduce the incidence in children that have had these vaccines. Okay, so let's look at just the tympanic membrane perforation fairly quickly. We know it's an opening in the membrane that separates the external ear from the middle ear. It is a cause of conductive hearing loss because the tympanic membrane is altered. Most perforations heal spontaneously, but some might require a referral. If they're really large or they don't heal. So the pathogenesis of this results from a variety of conditions. It can be trauma, infections, neoplastic processes. TMs can be lacerated or perforated by foreign objects, barotrauma, blast injuries, or fractures of the temporal skull. On occasion, from acute otitis media, all the pressure and fluid in it ruptures or perforates the eardrum, and they can precede the development of a cholesteoma. So clinical presentation, a thorough history will support the cause, generally. And then a thorough ear exam and hearing exam are needed for assessment. Diagnostics and management, an audiogram after the perforation is healed to assess hearing. And again, most heal spontaneously unless infected or very large. So generally we can just have a follow-up to assure that healing. Referral to the otolaryngologist is needed for large perforations or ones that don't respond. You want to always refer your patients with blast injury and or skull fractures because they're shown to cause inner ear damage, and that can lead to profound hearing loss. So patient and family education, you really need to protect that tympanic membrane while it heals. You want no water to enter the canal or near the TM. You also need to keep your follow-up appointment to assess when it has healed, or if it has not, to get a person to the right referral source. And just remind them, don't insert Q-tips or other objects in the ear. So my personal story, is my husband had a little Appaloosa horse several years ago, and he wasn't a very skilled rider. He was a novice, and he got on that horse, and that horse really kind of took off and took him right beside an apple tree. Now, I don't know if you're familiar with the branches of an apple tree, but they have like little fingers, and one of those small branches, fingerlings, went in and perforated his eardrum, and it was quite painful for him. Thank you for listening.